Good morning, good afternoon, good evening, everybody. It's Dr. Kaz, and I'm back with more fluid, electrolyte, and pH balance information. I'm going to pick back up with our hormones. Before we're talking about our renin-angiotensin 2 hormone system, mainly about the effects of angiotensin 2. And now we're going to move on to our antidiuretic hormone, also known as ADH. As you recall, ADH is synthesized and made in the hypothalamus. It is then moved from the hypothalamus into the neurohypophysis, the posterior pituitary, and stored there. And then upon signals or commands from the hypothalamus, the posterior pituitary will release the antidiuretic into our bloodstream. So what are some of the things that are going to cause the ADH to be released into our bloodstream? Okay, well, one is, we just talked about it, angiotensin 2. That will stimulate the hypothalamus to signal the posterior pituitary to release ADH, and this is done in response to low blood pressure. I also will see, that the hypothalamus, is going to receive input from the baroreceptors in our heart, and this because when blood pressure has dropped down, that sensory input is usually going to be decreased, and so that decrease in sensory input due to the decrease in stretch, because our blood volume has decreased and therefore will decrease our blood pressure, will stimulate the release of ADH. We'll see this, for example, in cases of severe blood loss, like if you're hemorrhaging, if a limb was cut off, for example, that will cause significant loss of blood volume and therefore a decrease in blood pressure. Also, we'll get information regarding the osmolarity of our blood concentration, and so the chemoreceptors are going to be the receptors that are going to transmit that information to the hypothalamus, and this is the largest role in stimulation for ADH release from the posterior pituitary. All right, so what does the ADH hormone do? Well, one, it's going to stimulate our thirst center in the hypothalamus, and therefore we're going to want to take in more fluid. And if we take in more fluid, we increase blood volume, and therefore if we increase blood volume, we increase blood pressure. This will then make our blood less concentrated, thereby decreasing the osmolarity here. We'll also see in the kidneys now, we are going to increase our water resorption in the kidneys. How does this work? Well, the principal cells are going to have an increased number of aquaporins inserted into the plasma membrane. And that increase of aquaporins will allow water to move much easier across those cells and into our blood. And so we'll see a decrease in the amount of fluid in our urine. And so, of course, since we are retaining the water in our bloodstream, we'll also see a decrease in our blood concentration or a decrease in our osmolarity in the blood. And then finally, vasoconstriction within our systemic blood vessels. And so since we're going to have increased peripheral resistance, that will increase our systemic blood pressure. Now, bear with me here. Actually, you don't have to bear with me. I will quickly type this out instead of writing it with the mouse. So keep in mind this equation, blood pressure is equal to heart rate, times total peripheral resistance. And that's what we're going to see here. So to increase our blood pressure, we can do it one of two ways. We can increase the heart rate, but ADH does not do that. But it does increase the total peripheral resistance. And since we increase our total peripheral resistance, we will therefore increase our blood pressure. All right, now we'll take a quick peek here at our, there we go. We'll take a quick peek here at the actions of effects of ADH in picture form. So we can see, right, up here in the brain, right, the stimuli that we discussed that are going to trigger the release of antidiuretic will be, right, angiotensin II production, right, and that's in response to a decrease in blood pressure, or if we have a low blood volume, right, therefore we'll get a decreased stretch in the baroreceptors in the heart, and then also the chemoreceptors pick up an increase in osmolarity in our blood. And so the hypothalamus is going to respond to that stimuli by signaling to the posterior pituitary to release antidiuretic hormone, ADH. And of course, ADH will then, right, flow throughout the blood, triggering the thirst center in the hypothalamus to increase fluid intake, thereby increasing, right, our blood volume and increasing our blood pressure. And then in the kidneys, we'll see more water resorption occurring because of an increase in the principal cells, insertion of aquaporins, and that will cause more water to move into our blood, less to be excreted in the kidneys. All right, and then that will also decrease the blood osmolarity in our blood and maintain our blood volume, therefore maintaining our blood pressure or increasing the blood volume, thereby increasing the blood pressure. And then finally, vasoconstriction in the total peripheral blood vessels there, increasing blood pressure. Right, folks, diabetes insipidus is our first clinical view of the day. And this is when we see a decrease in secretion, a hyposecretion of ADH, or the kidneys aren't able to respond to the effects of ADH. And so what we'll see is less fluid retention, more fluid production, or excuse me, urine production or excretion. And so these folks will be constantly having to go to the bathroom quite frequently. And you can see here, all right, a person can lose up to about 20 liters of fluid a day, which is quite a bit. Okay, our next hormone that we're going to talk about is aldosterone. This is a steroid hormone, and it is produced in the adrenal cortex of the adrenal gland, right? It is a mineral corticoid, and it is going to be produced in the outermost layer, the zona glomerulosa. Right? And so what triggers the response of aldosterone? Well, here we go again. Angiotensin II is going to be one of the things that will trigger, all right, the release of aldosterone. If we see, all right, a decrease in sodium levels in our blood, or if we see an increase in potassium levels in our blood. And that one is the big trigger for aldosterone. Increased blood potassium levels. That plays a big role here. So here's aldosterone. It gets released. It's going to travel to the principal cells there in the kidney. And so those cells are going to increase the number of sodium potassium ion pumps and sodium channels. Right? That is going to then cause an increase in the resorption of sodium. And as you know, water is going to follow the solute. Water is a follower. And so in this case, it's going to follow sodium. So if we increase the resorption of sodium, we're going to increase the resorption of water. So water is going to move back into the blood. But we will see an increase in the secretion of potassium. So we'll see increased potassium in our urine. Now, overall, we're going to decrease our urine output. Okay, so the urine volume will decrease, but we will see a maintenance of blood osmolarity. All right, that maintenance of blood osmolarity is going to make sure that our blood doesn't lose concentration or gain concentration. Okay. Okay, so when our blood volume and blood pressure, and when we get our electrolytes, sodium and potassium, all back to normal, then the amount of aldosterone is that is being released from the adrenal cortex is going to decrease there. So here you can see, all right, our beautiful picture here. All right, so the stimuli that are going to trigger the release of aldosterone, again, angiotensin II, right? When we see a decrease in our blood pressure, we can also see a decrease in our blood sodium levels or an increase in our potassium blood levels there. And that's the big trigger for aldosterone release. So of course, the adrenal cortex is going to release aldosterone into circulation, and then it will affect the kidney, okay, to decrease, or excuse me, to secrete more potassium into the urine, but it will decrease the amount of sodium that is going to be in the urine, increasing the resorption of sodium and therefore water into our blood. All right, so lastly, we have our atrial natriuretic peptide, AMP. All right, this is that a hormone that is going to work differently than those other hormones that we talked about, in the fact that it is going to decrease our blood volume and blood pressure. And so what causes the release of AMP is an increase in stretch on the atrial walls of the heart. And that's because we've increased blood volume and blood pressure, and that increases the stretch. So AMP is going to be released, and so it is going to decrease both blood volume and consequently blood pressure, because it causes, vasodilation of our systemic blood vessels. And when we cause vasodilation of the systemic blood vessels, going back to that equation, right, blood pressure is equal to heart rate times total peripheral resistance. When we cause vasodilation of the systemic vessels, we decrease the total peripheral resistance, decreasing blood pressure. Right, we'll also see vasodilation of our friends, the afferent arterioles in the kidneys. And at the same time, remember our mesangial cells, right? Those are the cells that are going to be found near our filtration membrane there in the glomerulus. And so what this does is it causes an increase in the glomerular filtration rate. And when we increase the glomerular filtration rate, we're going to increase urine output. And so therefore, right, we're going to see a larger volume of urine being generated. And we'll notice we're going to inhibit sodium, and therefore, as a result, water too, we're going to inhibit both sodium and water resorption. So if we're not resorbing, we are excreting or secreting, and so that is going to be part of the increase of our urine output there. And so if we have less water in our blood, right, then we will have a decreased blood volume and consequently decreased blood pressure. Also, AMP will inhibit the release of renin, so therefore we can have angiotensin II, and then it'll also inhibit the release of ADH, and it will inhibit the action of aldosterone. So it's quite a powerful hormone here. The effects of ANP, or atrial natriuretic peptide. So here is our picture, and here we can see an increase in blood volume causing an increase in the stretch in the walls of the atria, right? And so we will release AMP, and then AMP causes that systemic vasodilation, increases our glomerular filtration rate, which will then cause an increase in urine production. And as a result, we're going to decrease, right, sodium resorption, and thereby decreasing water resorption. So both sodium and water is going to increase in our urine, and that increased urine loss will have a decreased overall blood volume, and consequently that will bring down our blood pressure. And then don't forget about its inhibitory effects on renin, on ADH, and the actions of aldosterone. All right, let's move on into our next category. Remember, these videos that I've been doing, the past few videos, are talking about fluid balance, but also we're talking about electrolyte balance. Now we're going to talk about pH balance. So if you don't know it by now, you need to know it, all right? The normal pH in our blood is going to be 7.35 to 7.45, right? Normally we're looking for about a 7.4 as our set point value for our blood. So as you notice, it's going to be slightly alkaline. Now, if it falls outside of this range, then we fall outside of homeostasis and we lose that balance. That can be a problem because that proper pH is critical to body functions. If the pH falls considerably and our blood becomes too acidic, then we risk certain things like protein denaturation. That's the destruction of proteins, and you know all the wonderful functions that proteins, right, perform in our body. So we can't have it, and so it is critical that we maintain our blood pH, right, in that range of 7.35 to 7.45. Right, we talked about many inverse relationships in anatomy and physiology. One of the first inverse relationships that I talk about is that between pH values and hydrogen ion concentration. So as the pH decreases, something becomes more acidic, we increase our hydrogen ion concentration and vice versa. All right, so we do know that if something becomes too basic or alkaline, all we do is add an acid to it to offset, all right, that value, and vice versa. If, all right, we see that a solution is too acidic, we just add a base to it to, again, bring us back to that neutral level there. So there's two types of acids that we see in our body, both fixed and volatile, excuse me. Our fixed acids come from metabolic processes. For example, when we are exercising and working out, and so we start to break down glucose through the process of glycolysis, and we lack oxygen, then glycolysis will start to produce lactic acid. Right? If we start to break down fat, we will start to produce ketoacids. And so unfortunately, diabetics are more at risk for ketoacidosis because a lot of times without the aid of insulin for glucose metabolism, they are forced to use fat for energy processes there. And so we will see fixed acids are going to be regulated by our kidney. Our kidney is so very, very important, so many physiological processes in the body. So if you're ever taking a test and on the test it asks you about where does this process occur, you're really not quite sure, right? And one of the answers is kidney. I would recommend writing that down as your answer choice, just in case. All right, our next type of acid, all right, is a volatile acid. And so we're going to be talking quite a bit about this special acid here, carbonic acid, right here. And so when we're dealing with volatile acids, right, these are going to be, all right, carbonic acid is going to be an acid that is produced when we mix, if you look down here at our equation, right, when we interact carbon dioxide with water. And so volatile carbonic acid is a volatile acid because it is produced, all right, from expired gas or evaporated gas here. And so these types of acids are going to be regulated by the respiratory system, right? Where our previous acid, the fixed acids, are regulated by the kidney, our volatile acids are going to be regulated by our lungs, the respiratory system here. And so this equation, you should be very familiar with this equation right here, okay? Because we're going to be dealing with that. And of course, the almighty carbonic anhydrase is the very important enzyme that is involved in this equation when we are making carbonic acid or when we are creating carbon dioxide and water or hydrogen ions and bicarbonate there. Okay. So next, let's talk about some of the conditions that are going to cause an increase, all right, in our blood concentration of hydrogen ions. Okay, so of course, our diet, if the nutrients that we are going to be bringing into our body, any of the foods and whatnot, as we digest them, they are going to be absorbed from our digestive or GI tract here. And depending on the type of diet that you're on, usually diets that are high in animal protein and in wheat, right? Predominantly, all right, the Western diet that we see here in the US is a perfect example of that. So we will see that to be one of the causes that increases our blood pH, our blood hydrogen ion concentration. Also, normal metabolic processes that occur within our cells of our body, one of the byproducts, right, for our cells, these waste products, right, for example, can be our lactic acid. We talked about that when we're exercising, right? Phosphoric acid, we'll see that when we are breaking down nucleic acids, right? Also, right, consequence of getting sick. Unfortunately, there's a lot to worry about when you have food poisoning, but certain types of food poisoning can cause vomiting, but they can also cause, right, diarrhea. Certain just viruses can cause diarrhea. And so that is one of the other things that we'll see, right? When you have diarrhea, that can also cause an increase in our blood hydrogen ion concentration. Now, our kidneys are going to help to take care of all this. And so in response to these issues with our blood hydrogen ion concentration, we're going to try to resorb, quote unquote, that special resorption of any and all bicarb in the kidneys there in the tubule, all right, in the nephron. And so, right, while we're trying to resorb all that, we are going to try to make and absorb as much of that bicarb as possible. And we were also going to try to secrete and excrete any and all hydrogen ions into our urine and not add it back into our blood. So this picture is a lovely picture showing us right here, right, our diet, high in foods that are going to, when digested, are going to cause an increase in hydrogen ion concentration in our blood. And then also all these various metabolic processes that go on in our cells that are also going to put hydrogen ions into the blood. And then a loss of bicarbonate, right, from diarrhea will also, all of those are going to increase, right, the hydrogen ion concentration in our blood. So as a result, to rectify the situation, remember the type A intercalated cells are going to be the cells that are going to handle, right, blood when it's too acidic. Easy to remember, type A acid, blood is too acidic. And so what we'll do is we want to get rid of hydrogen ions. So we want to throw that into the filtrate and secrete that into the filtrate and then excrete it into the urine, thereby offloading our hydrogen ions, decreasing that concentration. And at the same time, we are going to try to dump more bicarbonate into our blood. So that will help to buffer the blood and bring our pH, right, back to that 7.4. That's what we're trying to do here, right? And that's what your kidneys are working on. Now, what happens if the other scenario happens in which we get a decrease in our blood hydrogen ion concentration, right? Not too often does this happen, right? I have heard stories about folks eating too much antacids. That's the guy that's always popping antacids like it's candy, right? Again, we don't see that too often, but it is a risk that we have to be concerned about. And in this case, right, folks that are vomiting, one of the scenarios that you have to be concerned about is folks with eating disorders, right, like bulimia. Okay, those folks obviously have a lot to worry about in regards to the food not sustaining nutrition because they're vomiting it up, but also because of all that vomiting, they can lose hydrochloric acid as a result of that. So again, the kidneys here are going to do their best to try to correct this scenario. So what they'll do is they are not going to resorb all of that filtered bicarbonate. And what we'll see is we're going to secrete the bicarbonate and eventually excrete it into the urine. And as that's occurring, we are going to resorb the hydrogen ions, right, to make sure we can offset this decrease in our blood hydrogen ion concentration there. So our kidneys are going to effectively be our buffering system. So the issue with our kidneys is, all right, normally a buffering system, and we'll talk about this here in a moment, all right, when we're trying to buffer our pH in our blood, all right, that usually takes a very short period of time. But when we get the kidneys involved, right, this can take a little bit longer, hours to days. but they are the best way, right, to maintain that hydrogen ion concentration in our blood, thereby keeping that pH value, that range there between 7.35 and 7.45. Right, here's our picture. Right, we have a scenario in which folks are ingesting large amounts of antacids, or they have a diet, right, specifically vegetarian diets, very healthy eaters. But what we'll see is, right, these folks will have a decrease in their hydrogen ion concentration. Right, folks that are having induced vomiting, or if they're ill and they're vomiting, they'll lose a lot of the hydrogen ion concentration from hydrochloric acid and the stomach secretions there. And so the kidneys then will try to offset this, because now that we have a decrease in hydrogen ion concentration in our blood becomes alkaline or basic. So B basic type B cells, I always remember B basic blood. Right, we're going to trigger our type B intercalated cells here. And so what they will do is they will offload the bicarbonate into the filtrate. They'll secrete it into the filtrate, thereby excreting it into the urine. And while that's occurring, we're going to see an increase in the absorption of hydrogen ions here into our blood, decreasing our pH back down to that normal pH range of 7.35 to 7.45. Okay, so that is, all right, scenarios when we're dealing with an increase or a decrease in our hydrogen ion concentration in our blood. Okay, next let's talk about the respiration and regulation of a volatile acid. Now think, we've talked about this before when we were talking about the differences in our acids here. We mentioned that the volatile acid has to do with the respiratory system. So think the lungs, okay? So our lungs, the respiratory system is going to regulate the volatile acid, carbonic acid. So pretty much when you are sitting here watching this video, okay, your body is going to get rid of, right, the amount of carbon dioxide that it has produced at the same rate. So the carbon dioxide that you breathe out and how much you're producing through just normal metabolic functions of you just sitting here should be equal to one another. Now that changes when you start to exercise or in emergency situations, right? And you'll notice here, okay, the three things that are going to affect your respiration rate that are listed here look familiar: carbon dioxide, hydrogen ion concentration level, and oxygen. Right, and that could be in the cerebral spinal fluid, but also in your blood. Carbon dioxide plays the largest role. It is the most important variable in the regulation of your respiratory rates. Then our hydrogen ion concentration, and then oxygen. So all this is going to be monitored by the chemoreceptors located, right, both in the area of where the cerebral spinal fluid is going to be located and also in your blood. So these three things are going to affect what your respiration center in the medulla oblongata is going to do, and therefore it is going to affect your breathing rate. So this is an important concept here. Carbonic acid levels are dependent on the carbon dioxide levels. So we can say the more carbon dioxide that is in your body, the more carbonic acid levels are going to be present, and vice versa. Now, carbon dioxide and carbonic acid do not normally have daily fluctuations. And so they are not normally going to affect what we're going to talk about here, about that acid-base balance there. Keep that in mind here. So this is just a nice picture showing you an example of how normal metabolic processes occurring in your body, right? For example, the mitochondria are offloading their carbon dioxide as a waste respiratory gas from aerobic cellular respiration, dumping it into the blood, It's going to travel through the blood up to the respiratory capillaries there, or the alveoli capillaries, and you are going to then breathe it off in an exhaled breath. And so that's where we're going to be getting, all right, our carbon dioxide, not just from that, right, but predominantly through cellular metabolic processes here. So that brings me to chemical buffers. Okay, so we talked way back, right, in another chapter, in another course, chapter 2 specifically, about buffers. And their job is to prevent changes in the pH value. And this is the one that is going to act quickly within minutes. So we have different types of molecules that are part of our chemical buffering system. But a chemical buffer, and this is important that you know this, can bind and release hydrogen ions quickly within a fraction of a second. So they're going to be predominantly made up of either a weak base or a weak acid. So if you're a weak base, you're like the sponge, you're going to bind or soak up excess hydrogen ions. And if you're a weak acid, you are going to release hydrogen ions. Remember, an acid is a proton donator. A proton is a hydrogen ion. If you are a base, you are a proton acceptor. And that's what we do. Unfortunately, these chemical buffering systems, right, are limited and are temporary. Because then we've got to get in our physiological buffering systems, and we'll talk about them, because the physiological buffering systems are going to be the systems that are going to get rid of whatever we have excess of, whether it is the acid or the base. Okay, so the buffering systems are like that little boy putting their finger in the dam, stopping the flow of water or the leaking of water for a short period of time. Right? And it's not until the physiological buffering systems, right, move into effect that we're going to eliminate and get rid of the excess acids or bases there. So we have three, okay, components to our chemical buffering systems here. Proteins, and pay attention to this too. Our proteins, where are they located? Well, they're located both inside the cells and outside the cells, in the cells and in our blood. Phosphate, in the cells. And then bicarbonate, that's going to be in the extracellular fluid, right? But primarily in our blood plasma there, okay? So proteins, phosphate, and bicarbonate. So the protein buffering system, you can see here, right, it is going to make up 75% of the chemical buffering in your body fluids here. So we have proteins in our cells. We have tons of proteins in our blood plasma. Here's the famous oxygen carrying protein, hemoglobin. And so again, their job is to make sure that we don't see big swings in the amount of pH changes that occur. Now, proteins are wonderful structures, okay, right? They bring it to the party because they both have an amine group and a carboxylic acid group. The amine group is going to act as our base, all right, that weak base, so it can buffer acids. And the carboxylic acid is going to act as a weak acid, and it's wonderful because it can buffer the base. So proteins are awesome. They're one of my favorite macromolecules. And I know I say I have a lot of favorite of whatever, but proteins, they definitely bring it. What about our phosphate buffering system? Okay, our phosphates are found in the intracellular fluid here, right? And so their job is going to be to buffer the metabolic acids, right? That's that lactic acid that we talked about, okay, the ketoacids and whatnot that are going to be produced by these cells. And so the phosphate buffering system, right, can be a weak base and a weak acid. So you can see here, hydrogen phosphate, that's our weak base, and then our dihydrogen phosphate, that's our weak acid. So basically, when we check out the net result of all this, right, and this is going to be common for what we're talking about, a strong acid can be buffered and produce a weak acid. And then therefore also a strong base can be buffered to produce a weak base. And we're going to see that also here with the bicarbonate buffer system. All right, same thing. If you jump down here, right, when we look at the net result, the same thing with the bicarbonate buffer system. All right, a strong acid can be buffered to produce a weak acid, and also a strong base can be buffered to produce a weak base. So this one plays a huge role in the extracellular fluid here. And so our weak base is going to be bicarbonate, and our weak acid will be the carbonic acid. Now, of course, these chemical buffering systems have a limit. They can only do so much. Remember, they're temporary and they are limited. So when they reach that limitation there, right, that end area, okay, we call that the buffering capacity. That is the limitation, the amount of acid or base that they can buffer. So that's going to lead us into this next part, and that's where we're going to talk about our acid-base imbalances here. So when we look at our blood, the pH value of our blood, if we fall below that 7.35, then we're dealing with what we call acidosis. If we are above the 7.45, then our arterial blood is going to be alkalosis. So the acid-base disturbance, you should know this, is when we've exceeded our buffering capacity, right? We just cannot, all right, maintain that normal 7.35 to 7.45, and we've swung into either acidosis or alkalosis, right? And that's because we have, right, a change, right, in our hydrogen ion concentration, either too much or too little. So now we need to respond to this imbalance here. So when we're having a physiological, now this is where we call them the big guns. We're going to have our physiological buffering systems come in. And so when they're brought on board, we call that compensation. Unfortunately, if they are not effective, then we call that uncompensated. So let's start off with our first acid-base disturbance here. We're going to talk about the 4 different types here. We have respiratory, and anytime you think respiratory, you should think lungs, right? And then when you see metabolic, you should think kidneys, right? So respiratory is lungs, kidneys are going to be metabolic. So our acid-base balance is not going to be temporary. It is going to be persistent in our pH change. And anything that is left unchecked for a long period of time, especially in a carefully regulated system, can be life-threatening, and that's bad. So we're going to break down and classify these different types of acid-base disturbances, right? The first word in the disturbance is going to tell you where this is going on. So it's respiratory, lungs, metabolic. In our tissues, primary issues with the kidneys are going to be brought on board. And then, all right, what the pH change is going to be will be the second word. Is it acidic or alkaline? So respiratory acidosis, we're going to talk about, that is the most common type of acid-base disturbance. And what we're having an issue with is getting rid of carbon dioxide. This goes back to what I was saying before. Remember, carbon dioxide levels and carbonic acid levels are going to be equated with one another. If you have more carbon dioxide in your body, you're going to have higher levels of carbonic acid. So the partial pressure of our carbon dioxide normally in our blood is about 45 millimeters of mercury. Well, in this case, right, we are going to see an increase in that partial pressure of carbon dioxide because we have more carbon dioxide. Why? Because we can't get rid of it. And as we can't get rid of it, we accumulate carbon dioxide in our blood. And as a result of that, we are going to get an increase in the in our hydrogen ion concentration in our blood. We see this all the time in babies, okay? Smaller lungs, lower residual volume. They have more respiratory issues here. So what are some of the causes? All right. The primary cause here is hypoventilation. You cannot exhale enough and and breathe off that carbon dioxide. Head trauma, very common, especially to the brainstem, the medulla oblongata. That is where the respiratory center is going to be, okay? Or the effectors for breathing, the muscles, right? If you injure your phrenic nerve, right? C3, C4, C5 spinal nerves will make contributions to create the phrenic nerve. If there's damage to any of those nerve roots, right, or to the phrenic nerve, right, that can be an issue. Some of the other nerves, some of the excuse me, not other nerves, the other muscles, okay, are intercostal muscles. So issues with that can cause hypoventilation. We talked about that in the respiratory chapter. What about a decrease in airflow? Maybe there's an obstruction somewhere along your airways there. Or you can be like me and have asthma, and that can cause issues because you're getting bronchial constriction because the smooth muscles are in spasm, and that bronchial constriction is increasing resistance, thereby decreasing airflow. Or we can have an issue with the exchange area for our gases. Remember that respiratory membrane there? So if we have impaired alveolar gas exchange, right? We saw that with emphysema. Okay, we lost alveoli, so we have a decrease in the surface area there. Or if you have an infection, maybe you're in the hospital with, unfortunately, COVID, you can get a thickening of that respiratory membrane, making it much more difficult for the diffusion of those respiratory gases into the lungs or out of the lungs, into or out of the blood. So that is the most common type of acid-base disturbance. The next one is respiratory alkalosis. Now, the partial pressure of carbon dioxide is now below 35 millimeters of mercury. This is going to be because you are hyperventilating, increasing the rate and the depth of your breathing. And because of that, you are breathing off more carbon dioxide. So that's going to cause a decrease in carbon dioxide, and that is going to lower our hydrogen ion concentration. What are some of the causes? All right, panic attack, anxiety is a perfect example. Or you decided to go climb a mountain and you didn't properly acclimate yourself to that increase in altitude where the air is thinner. So you are getting decreased oxygen to your cells. We call that hypoxia. All right, CHF, congestive heart failure, or if you're having some sort of anemia because you have decreased red blood cells, or the hemoglobin that you have is not effective in carrying oxygen. All these things can cause issues for hypoxia. And then, of course, respiratory overdose, that is going to, in fact, affect the respiratory center there in the medulla oblongata, and that too can cause hyperventilation. So this picture here is showing us, all right, some of these examples. Okay, I apologize about that. I had a brief technical issue, but my internet is good to go. So let me resume here and just show you in a little bit of picture form here what we're talking about when we're dealing with the lungs and the respiratory issues here. So what this picture here on the left is showing us, all right, when you're having an issue with impaired respiratory function, okay, we're not able to breathe, for example, our normal respiration rate is decreased, and as a result, we're not able to expire as much carbon dioxide in our breaths. That's going to cause an accumulation or an increase in carbon dioxide in our blood. So that's going to drive this awesome reaction here from the left side to the right, resulting in an increase in our hydrogen ion concentration. So that's that respiratory acidosis. And then we move over here to the left side here, and you can see now if we have some issues with an increase in our respiration rate, for example, a panic attack, this person is going to now expire more carbon dioxide. And so because of that carbon dioxide being breathed off more, that's going to force our reaction from the right here towards the left. So now what we'll see is a decrease in the hydrogen ion concentration because we're forcing it to produce, all right, that water, and that carbon dioxide is exiting out of the lungs because it's being breathed off. So we see less carbon dioxide, less, all right, hydrogen ion in our blood. That causes an increase in our pH. All right, so let's talk about the last two acid-base disturbances, our metabolic acidosis. So when we're dealing with metabolic acidosis, it's either going to be from a loss of bicarbonate or a gain of hydrogen ion. And the gain of hydrogen ion is going to be the much more common issue that we see. And so what we'll see, as you know, all right, from our equation that we just took a look-see here, the hydrogen ion is going to bind to that bicarbonate there. And so when it binds to that bicarbonate, that is going to decrease the levels of both, all right? And so what we'll see here, right, especially again, with infants here, because what do? They sleep and they poop and they pee, but they're growing. And so their cells are highly active. So their cells are going to produce a lot of metabolic waste, but particularly acidic metabolic waste here. And so we have to be careful with babies and dealing with that metabolic acidosis here, right? So, right, it can come from a various level or variety of different types of processes. We talked about the lactic acid production from glycolysis. Again, keep in mind, if oxygen isn't present, we're going to shunt that reaction to produce more lactic acid, right? Diabetics, right? Because there's that issue where they don't have insulin with glucose metabolism, they're forced to break down fats, so they're more prone to ketoacidosis. Alcoholics are more prone, all right, to acetic acid, right, because as it starts to break down alcohol, that ethanol there, it is going to be converted into acetic acid, and that can accumulate there. So we have to be careful, all right, because any times that we move in, and we talked about, all right, some of the issues when we're dealing with, all right, high hydrogen ion concentrations in our blood, but primarily the kidneys are going to clear those hydrogen ions. But what happens when we're dealing with kidney dysfunction? Right? If they cannot clear that acid, then we start to get that accumulation there, and we can start to run into problems. And that's what will be one of the results will be that metabolic acidosis. Also, severe diarrhea, because we're getting rid of all that bicarbonate in that diarrhea, right? And we don't have the bicarbonate there to buffer those hydrogen ions. That too can be one of the causes for metabolic acidosis. And then our metabolic acidosis, right, we're going to see either a loss of hydrogen ions or an increase in the bicarb. And some of the causes we're going to be, right, vomiting. This is going back to, like I said before, folks that are bulimic, or if they're very ill, okay, from an infection, or if they have some sort of trauma there in which they're vomiting. That's the most common cause, right? But we can see, right, diuretic overuse is another cause that will cause an increase in the loss of acid from the kidneys. And then this is much more rare, but going back again and talking about our antacids, ingestion of large amounts of antacids. We see that in folks that do not take very good care of themselves and maybe are having some GI issues, and as a result of that are using the antacids to treat that GI issue and then causing another issue. So our second clinical view of this video is our lactic acidosis and the ketoacidosis. And I've briefly talked about this in the past, but lactic acidosis, again, when we don't have enough oxygen during that process of glycolysis, when we're breaking down the glucose, right, because we don't have the oxygen, right, to shunt that pyruvate into the mitochondria, right, then what we'll see is, right, a large amount of lactic acid being produced. Now, the nice thing is, right, we can actually take that lactic acid and swing it back to the liver, and through the process of gluconeogenesis, we can generate glucose again and try it all again if the oxygen levels are available. Ketoacidosis, right? Unfortunately, this is a result of large amounts of keto acids, which are produced from fat metabolism, right? Diabetics, unfortunately, are at risk for this because they are unable, all right, to metabolize glucose. So the body's like, well, if I can't have glucose, I'm going to go after fat. and it will start to break down our fats. And as a result of that, you will get an increase in those keto acids, right, contributing to that ketoacidosis, something you have to be on the lookout for. So how does the body deal with this? So it's going to rely on the kidneys and the lungs, primarily the kidneys. Okay, so those are going to be the physiological response mechanisms to the changes in the pH. So if our pH, all right, elevates, not elevates, if our pH levels drop, or if our hydrogen ion concentration in our blood increases, right, then the kidneys are going to try to work on this. And we'll talk about how they do it just briefly, right? But obviously, this will occur as long as there's no renal dysfunction. Okay, if there's renal dysfunction, the kidney, and it's with the kidneys, and the kidneys can't fix the problem, right? So we have to consider that there's no renal dysfunction, and so our blood has become acidic. Acidic is A. Our type A intercalated cells are going to be called hydrogen ions. So they're going to excrete the hydrogen ions in the urine. So they will secrete the hydrogen ions into the filtrate. And then from the filtrate, we will then move those hydrogen ions into the urine to be excreted. At the same time, those type A cells are going to resorb our bicarbonate into our blood. And so we'll see, all right, our bicarbonate levels in the blood, all right, kick up. And so our pH will start to go back to its normal levels, okay? But our urine will have a lower pH than normal because of the high concentration or the higher than normal amount of hydrogen ions moving into it. So what happens when we have a decrease in our blood hydrogen ion concentration or an increasing pH? Well, blood is now basic, right, because the pH is increased. So we're going to bring into play here the type B intercalated cells. And so opposite situation happens here. We are going to excrete into the urine, all right, the bicarbonate, and we're going to resorb our hydrogen ions. And that resorption of the hydrogen ions now is going to decrease the pH in our blood. And so what we'll see in our blood, our bicarbonate levels are going to be low, and then our urine pH will be higher than normal. So this is, like I said, the kidney is the big gun here. And so it is going to be quite effective when we're trying to neutralize those, as long as there are no renal or kidney issues. And then finally, all right, compensation regarding the lungs, all right, our respiratory compensation. All right, so what we'll see is we're going to change our breathing rate, our respiratory rate. So we'll see an increase in our respiratory rate when we see an increase in the hydrogen ion concentration. Why is that? Well, as you know, right, if we increase our respiration rate, we will breathe off that carbon dioxide. And so if we breathe off the carbon dioxide, we will lower the levels of carbon dioxide in our blood, and we will also lower the levels of the hydrogen ion concentration in our blood, and vice versa. Our respiration rate will then decrease when we have, all right, a decrease in our hydrogen ion concentration in our blood. And so that will start to increase our blood carbon dioxide levels, which will then increase the concentration of hydrogen ion in our blood. And so we have to always consider, in this situation, when we're dealing with hypoxia, right, we don't want to limit, right, the amount, because if we're decreasing our respiration rates, right, we are going to be breathing in less oxygen. So we have to be careful, because we don't want to limit the amount of oxygen that we're bringing into our blood, because our tissues still need that oxygen for their metabolic processes. Keep in mind, less effective, right? The respiratory compensation is going to be less effective than the renal compensation. That's why I always say the renal compensation is the big dog. That's the one that's quite important. All right, folks, I hope you enjoyed this video as much as I enjoyed making it. You have a great day.